get us started. I can see that our presenter is online. That's Dr. Andrew Okiko. My name is Dr. Phoebe Juma from Kenyatta National Hospital. I'm a physician working in the infectious disease unit. So today we have our second presentation, which is the second part in a series of 3 presentations. And today we'll be tackling antibiotic selection for the treatment of pneumonia in adults. So I'll invite our presenter, who is Dr. Andrew Okiko, who is a clinical pharmacist and also a member of the Antimicrobial Stewardship Committee at Kenyatta National Hospital, who will be taking us through this presentation. If you have any questions, please post them on the Q&A, and I'll also be monitoring the chat. Thank you. Dr. Okiko, welcome. You can share your screen.
Thank you. I hope you can hear me, Dr. Juma.
Yes, I can hear you.
Thank you. Yeah, thank you. Thank you for the introduction. We've been doing, I think, a series of community-acquired pneumonia presentations. So today we'll be talking about the antibiotic choices, more specifically for the that we've collected so far in regards to both community-acquired pneumonia, and we'll touch a bit on HAP guidelines. Thank you. So this is what we'll attempt to answer in the next few minutes in our presentation. We are a group of about 6 who did this. So I think some of my colleagues are in the panel, and they'll assist in this presentation. So we'll talk a bit on the antibiotic choices for CAP and HAP. We'll consider the KNH hospital antibiogram. We'll also attempt to answer the rationality for combination antibiotics, shoulder microlide or fluoroquinolone or beta-lactam, and look at the efficacies. We'll also attempt to answer the need for oseltamivir in therapy for severe community-acquired pneumonia. We'll attempt to also answer on the prediction scores for drug-resistant pathogens, especially in CAP, and look at also when to add therapy for PCP, empiric treatment for TB, and dosing of antibiotics. So we can, I think it's a discussion, but once I've done the presentation, you can hear from you attendees. Thank you. So I don't think I need to delve much into the definitions for CAP, but you all know this typical CAP, and usually I think the organisms that usually involve strep pneumonia, which is the same case for us. And then the atypicals, it's been varied, I think, from the researches that we saw. There are several pathogens that cause atypical, and in the African perspective, particularly in Kenya and refugee camps and what we see in the hospitals, the prevalence is really varied from 2% to almost 10% in most of the research data that we got. So we'll share a bit of it. So when you look at our, I think presenters have talked much about the CAB score, CAB 65 score. So we'll just delve directly into the empiric therapy. We adopted this from as much the WHO, we felt it's still the same. And I'll share the reasons why. First line, we still maintain amoxicillin TDS for 5 days. And as an alternative, especially for mild CAP, we say the alternatives are the clarithromycin 500 mg PD for 5 days, erythro or azithro. And doxy also comes in here because we noted from our data, doxy still has quite good coverage in this regard. Yeah. This is the chart that the KNH guideline has advised. So when you look at this chart, it's an algorithm for antibiotic prescribing. This was shared. So it tells you how to categorize your patients and who will need and what steps to take once you discover what we are trying to encourage here is collection of samples for microbiology. And we hope we can gather enough data to inform guideline change, I think in the next year or so. So this chart, we're encouraging a lot of our clinicians, at least we try and gather enough samples where appropriate so that you can review it. With more particular interest here is to note that our guidelines, we are trying to protect the carbapenems. So for carbapenems, we ask that we'll need an approval, an infectious disease physician approval for carbapenem. There's quite a lot of evidence for combined antibiotics. So here we're saying beta-lactam plus a macrolide for moderate CAP. All patients for moderate CAPs, there is a beta-lactam. And if you look at the dosing, we've maintained TDS for this is 1 gram. Yeah, and we maintain TDS for 5 days plus clarithrol, either VBD for 5 days. Erythro and azithro has come in very handy, and we see that their kinetics are more or less the same, so we really have no need to fear. Yeah, so the alternatives still remain clarithrol and doxy. I'll share a bit on the antibiogram that we got, the latest one from the lab in a few days. For severe it still maintains beta-lactam plus a macrolide. Because that has come out with the levofloxacin, and usually pseudo is a bit resistant to moxi, so level good kind of. I think several studies we got. One of the strongest studies that has for patients.
Doctor.
Okay. Am I?
Yes. Okay, now I can hear you and I can see your slides. Yeah.
Okay. Yeah, so this, we're on the slide for rationality for the combined therapies. So we compared, we looked at the several studies that compared these regimens. And the unique thing is that none of them was, all these therapies were effective. The efficacies were quite as good for non-severe pneumonia. So all patients responded very well for beta-lactam plus a macrolide, beta-lactam plus doxy. So all were quite good. When you dig deeper, I think the minute differences were in hospital mortality, where if you look at it's 7.5% using the beta-lactam plus macrolide, 9.7% mortality, slight difference, using a beta-lactam alone, 6.7% using a fluoroquinolone, and 6% the combination of. We compared in terms of longer time to discharge, BL alone was associated with a longer time to discharge, so which basically makes sense because it depends on the organisms you're targeting. If probably there was typical organisms you might have missed. So this, but still, on all of the three groups, they're all non-inferior. So it means all of them had good cover. So I think when we looked at safety profile, at side effects and availability, we settled on beta-lactam plus amacrolide, which is in line with the WHO guidelines so far. Hence, we answer the question that none of these therapies are inferior. So basically, we're still safe with the beta-lactam plus amacrolide, but it's good to note that this data was done in many different countries. We could not get a local study that has compared this. So it is important because the patient profile are different.
Sorry, Dr. Kiko, I think you're muted. Dr. Kiko? Dr. Kiko, I can't hear you. You're muted.
Sorry, my network, I think, has a challenge. Sorry. So we attempted be added to the therapy for patients with severe pneumonia. And most of the data that we got is only if it's confirmed by PCR. If you confirm influenza by PCR, then there are papers that have shown that early initiation of therapy improves survival rate. So locally, I think one of the biggest challenges is availability of oseltamivir and the cost. But yes, there is evidence that there is moderate evidence to show that it improves survival rates. So yeah, for patients where there is confirmatory PCR, there is evidence for a better outcome with this therapy. Then when should you start antibiotics? All the data says as soon as possible, and certainly within the 4 hours, at least 4 to 24 hours, the outcomes are massively improved. So oral antibiotics are just as good as IV antibiotics. So where possible, and I think patients, most data shown that patients should be on oral antibiotics if they can, where possible. How long? 5 days so far. Most of the data shown 5 days, except, I hope I'm still on, except for patients who are immunocompromised, who have an underlying structural lung disease, yeah, and those ones who do not respond, especially in the first 72 hours, the patients at least you need to consider long-term therapy. And where you have identified these non-traditional CAP pathogens, these maybe the typical Legionella, Pseudomonas, stuff, they can be quite problematic. So those justify about 7 days of therapy. Yeah, but common CAPs, 5 days is still sufficient. So when you look at our guidelines, we've stuck to the same. A duration of treatment is 5 days for CAP and 7 days for HAP. I think this is more summarized. It's more or less the same. I think I've just expounded this definition. Yeah. So doxycycline has really strongly come in our guidelines for CAP. So we attempt to enter this could lead to more appropriate therapy and improved outcomes. For all the data that we looked at, for us is no. There's really not really a good prediction score for a DRP, especially in CAP. All the data that have shown that if you look back, I think the criteria had a definition called healthcare acquired pneumonia. And this, in quotes, was for patients who've seen, it's more like the patients that we've seen Kenyatta who've come with referrals. So they could qualify in this, but the outcomes, and in essence, there was over treatment, and it sort of twigs you to use broad spectrum antibiotic therapies, and the outcomes are not really very well. So this
sorry, I think Dr. Okiko, you've dropped off again.
Sorry. Can you hear me now?
Yes, you're audible.
Hello, Doctor.
Yes, I can hear you. Dr. Okiko, you can go ahead. Ooh.
Sorry about that. I think my internet is a bit unreliable. So for this, I think the best, if we can get a good molecular diagnostic criteria, which for now we really have an available, easily accessible, we can get a point of care much better. But for now, we could not get any criteria that could support a prediction score for DRPs. This I'll throw out again to the. So the guidelines are robust for CAP for in our situation. When to add treatment for PCP. For immunocompromised patients, especially for in the HIV AIDS patients, this we said we can use the guidelines. The current guidelines are quite robust for in HIV care. I think there's a lot of research in that level. For organ transplant patients, we said team. I think the only advice here is it's not advised to use cotrimoxazole long term for transplant patients. So it's specific. Most people use, I think, 6 months to 1 year. It depends on local regional guidelines for PCP prophylaxis. And then for treatment where you have a high suspicion of PCP, in liaison with an ID specialist, then we say you can start treatment. The drugs of choice in local guidelines still starts with the cotrimoxazole as a first line. That's across board for both immunotransplant patients and immunosuppressed patients. Yeah, basically we are saying when you consider empiric treatment for TB, we looked at several guidelines, the South African guidelines, the local guidelines. There were challenges, I think, from how we discussed a lot. And hospitals actually say that with the advent of gene experts, it substantially increased the detection of TB cases among populations, both for co-infected TB and general patients. So sensitivity for gene expert is quite good, and specificity is very good.
Oh no, Dr. Okiko, you've dropped off again. Sorry, I can't hear you.
So,
oh, yeah. Dr. Okiko, you are dropped off a little bit. Maybe you can just recap the last slide.
I'm saying, am I back?
Yes, now I can hear you. Yes.
Like here is to discuss the data and the most guideline that you saw.
Okay, we can't get you well. I don't know if you're a bit far from your mic.
Juma, can you hear me?
Yes, now I can hear you, but the volume is low.
What about now?
Volume is better, although a bit of static, but.
Sorry, okay. So we are saying that the use of gene experts should be encouraged in most facilities where possible. The biggest challenge we have is the cost, availability of reagents, and the technology. If it can be disseminated in most centers, this will be the best. Yeah. So we talked a bit with the TB team, and those are the challenges that they exposed. And hence, we still, I think for Kenyatta, we not badly off in terms of reagents, but we can do better. And basically across board for best practice, we should try as much as possible to use the gene expert to be more targeted therapy instead of having over treatment of TB for many cases. So we'll take a look at the HAP guide. In terms of antibiotic choices, the suggestion is that any patient with HAP should be treated. The best treatment guide is the lab results that we get from the cultures. And we cannot underscore this. I think this is the most important step in treatment of HAP. So we recommend also empiric choices to use clinical criteria. Yeah, it's more accurate from all the data that we've seen. PCT is still good, but the clinical criteria actually overrides a lot of the data that the results that we've seen. This was a strong recommendation from most of the papers that we looked at. Yeah. The other thing is that we noticed that there are studies that have come out with a few patient risk factors that can be taken into account when you are doing your antibiotic choices. So one is use of an IV antibiotic within 90 days, septic shock at the time of HAP, RDS, VAP, and then a history of hospitalization. I hope I'm still audible, Dr. Juma.
Yes, I can hear you.
Yeah. Okay, yeah. So these are risk factors, but used for empiric choices, not as such, not yet in the guidelines. So this is an attempt by different people that we looked at antibiotic choices, so to assess for DRPs. So when you look at, when you have an HAP pathogen, so we look at the low risk based on a criteria above. So you can categorize the patient and help you choose. So if empirically you can do a monotherapy or you do combine. So this is an attempt to come up with an algorithm, I think. But for now, this is what our antibiogram is showing. I'll come back to this algorithm. So let's look at our antibiogram. We have analyzed blood cultures, and we looked at top 3 organisms and look at their susceptibilities. So we look at tracheospirates and a bit look at the blood culture results. So when you look at this antibiogram, this is the last quarter to September. The KNH antibiogram, I think from July, August, September, for the last 3 months. And when you look at it for Enterococcus species, the red one shows you resistance. The green one shows the sensitivity, susceptibility. So if you look at Enterococcus species, tigecycline, levofloxacin, gentamicin high dose, erythro, ampicillin, penicillin, colistin, basically our choices are really limited. So we are saying teicoplanin, linezolid are still good. I think what was missed here was vanco. We would have loved to see vancomycin, but vancomycin and teicoplanin are more or less the same susceptibility. So when you look at this data, it's worrying where the trend is going. But then that tells that Enterococcus species, we still have the teico, linezolid, vanco are still susceptible. When you look at E. coli, we basically, the patterns are showing ampicillin resistance, ceftriaxone, CRO is ceftriaxone, CZO is cefazolin. When you look at all this data, it means we only have Genta, meropenem, amikacin with us that are still susceptible at the data. So this data doesn't change much when you look at last year's data. I think is the data that has helped us to come up with the guidelines. So we have put meropenem as an antibiotic that we want to, as a rescue antibiotic. So that's why we've restricted its use. Yeah, and then we've used amikacin in several combinations because of the patterns that we are seeing here. For Klebsiella pneumonia, these are the patterns that you're seeing. Susceptibility is still good for Genta, meropenem, amikacin. When you look at all these other cefazolin, ceftriaxone, cotrimoxazole, ceftazidime, we have a challenge still in the hospital setup. Yeah. So this data is actually still worrying for us. So we'll look at it in the next quarter and see that there is a slight change in this. But for Staph aureus, we feel we are much better in Staph aureus actually. We still have sensitivity for several of our antibiotics, levoflox, Genta, tobramycin, colistin, vanco, they're still quite susceptible. The antibiotics are still quite good for Staph aureus. When you look, this is the most worrying actually. Acinetobacter is one of the most difficult organisms that you have in the hospital to treat. In the last quarter, we only have gentamicin that is still susceptible, almost, it's at that 51%. But basically, of all our drugs is sort of, we have very low susceptibility. Yeah. So let's look at tracheal, these are tracheal aspirates. the patterns are not really different when you look at, compare the two. We still have amikacin, meropenem, Gentar. For Klebsiella, this is for tracheal aspirate. Same for Staph aureus. We have Takol, Linezolid, Colistin, Vanco. Still very good. Gentar is still very good. If you look at these two, for Pseudomonas, usually quite problematic. We still have Piptazo, meropenem, quite good for tracheal aspirate. Yeah. So this is what has helped us to come up with the guidelines that we have. I'll jump this because I've basically spoken about it. This is our lab data. So, in summary, what have we been saying? For KNH, this is our guideline. For CAP, we still stuck with the beta-lactam and macrolide. For HAP, we have said these are top 3 organisms. So we've said we stuck with Piptazo for empiric therapy. Then we de-escalate down depending on the lab results. Then, where suspected Pseudomonas species, the Ebomani, empirically we are saying we combine with amikacin, Piptazo with amikacin, and where there is a high risk of MRSA, then we consider linezolid or vancomycin, yeah, in our setup. This is the summary for what we're saying. The FIPIM has come in many different setups because it had quite good profile for different organisms, and it's a good rescue form where patients cannot use Piptazo. Yeah, so Cefepime has come in really for that. Thank you. Back to you, Dr. Juma. I think I've covered summarizing most of our guidelines. Back to you, Dr. Juma. Sorry for the internet.
No problem. Thank you, Dr. Okiko, for that presentation. I'm seeing there are several questions on the Q&A. So maybe I'll just go straight to the Q&A. So the other panelists were not able to join. We had hoped microbiologists would be online just to help with answering questions on the antibiogram. So I'll just go straight to the Q&A. So the first question, my question is about using a beta-lactam plus macrolides. So do you use macrolides to cover for a typical pneumonia?
Yes, that is for typical pneumonia. We are saying because we don't really have enough profile, especially in our patient. I think what we lack is profiling our patients to identify the prevalence of atypical organisms within our local setup. All the challenges we have. But if in terms of efficacies, this was the best combination that we thought would cover our setup. Unless Dr. Juma, you have a feedback on this.
No, I think you've answered adequately. So we add on the macrolides to cover for typical pathogens because the yield of tests take time to give results, and the yield of tests is also not good, as you were told in the presentation on Monday. So the next question is, I think, similar. They're asking, why should you combine a beta-lactam and a macrolide?
I think this is answered in the slides. Yeah? All combinations are still effective. When you looked at beta-lactam plus macrolide, beta-lactam alone, fluoroquinolone alone, or beta-lactam plus doxy, all of them were still effective. The efficacy was more or less the same. Why we narrowed down to beta-lactam plus a macrolide is 1, because of availability of these 2 drugs, and 2, because of the safety profile. I think fluoroquinolones have had very many safety profile issues, and hence it's a reserved drug. Plus, it's also used in TB, so it will be better to actually sort of save fluoroquinolone. Thank you. Back to you, Dr. June.
Yes, maybe there's also an issue about fluoroquinolones causing, is it Achilles tendon rupture? Although I've not seen cases among my patients.
For,
I don't know what your experience
I
has
think
been.
it's for long-term use maybe, but for short-term use, it's not really been documented on short-term use, no.
Okay. So the next question is, someone was asking whether we could review some slides which had problems because of internet. But this presentation has been recorded and will be uploaded on the KNH website. So you'll still get a chance to review the slides. There's another question on where can I get the KNH guidelines. So the KNH guidelines are available for KNH staff. They're at KNH. We have soft copies and hard copy as well. So what Dr. Okiko has said is that the antibiogram we've used to develop our guidelines was based on samples collected in our lab. So it's specific, maybe I'd say for our facility and our population. So for a different facility, maybe in a different part of Kenya, you'd also need to develop your own guidelines based on the data that you're getting from your lab. So it's not possible maybe put to use an antibiogram for another facility, for your facility. There's a question about cephalosporins. So this anonymous attendee is asking, do third generation cephalosporins have a role in the treatment of community-acquired pneumonia? Dr. Okiko?
I think I'll attempt to answer the whole, because I can see it's asked also, can azithro be used instead of clarithrol? And do you have to classify patients as having comorbidities before selection of antibiotics? Third generation cephalosporins, I think they have a role in CAP, more especially for PIDs. I think it's good that you say that these guidelines are more for adult population. Looking at our antibiogram, we settled on cefepime because it had a very good coverage. But looking at generally the patterns of resistance, we've said that we settle for cormoxiclav because of availability, 1, and 2, it's been studied a lot more, I think, from from the research data that we got. But yes, third generation still have a role in treatment of CAP. If you're able to get your lab data in place, it still has a role. Azithro, yes, it can be used instead of clarithrol. I think the profile is still the same. The kinetics are more or less the same. The OD dose is still good and it's still quite as effective as clarithrol. Thank you.
There was the last
part. In terms of morbidities, most data is only on the duration of antibiotic usage. So patients with comorbidities, you're better off going for up to 7 days. Patient profile who are stable, they can do 5 days. Thank you.
Okay, thank you. Maybe just to add, for the third generation cephalosporins, so there's been really heavy use of rocephin for many conditions, and from our antibiogram, there's a lot of resistance. And even we preferred to use amoxicillin clavulanate. It had better activity than ceftriaxone. And that's why we've moved away from cephalosporins, third generation cephalosporins, and we are more on the beta-lactam, amoxicillin clavulanate, amoxiclav, tazobactam, piperacillin, and as a last resort, we'd rather use even meropenem, acabapenem, and maybe an aminoglycoside. So let me see the next question. In part 1 of the webinar, the presenter said the routine sputum culture and sensitivity is not recommended in patients with CAP. So he's asking, how do you then escalate or de-escalate antibiotic therapy after starting empirical treatment?
From our setup, we looked at, I think this is mainly a statement for outpatients. And outpatient setup, I think the guidelines are quite robust in terms of antibiotic choices. So routine sputum culture does not significantly improve the outcomes unless there's new data to that effect. Yeah, for HAP, then it makes sense to do cultures. Then you can de-escalate. Tajuma can comment.
Yeah, so from our guideline, there are different categories of patients with pneumonia. So those patients you're going to manage at home, you don't need to routinely do tests. I think that's the message that he gave us. And even for inpatients, for those stable patients, hemodynamically stable patients, you can just go ahead and start them on therapy, then monitor them, because the yield of culture, sputum culture and sensitivity is not good. So for those, there are certain category of patients the presenter had mentioned where you'll need to do tests. And these are the patients who have severe pneumonia. And there's actually a criteria for classifying which patient has severe pneumonia. Then also for those patients who have drug resistant, high risk of having MDR bugs, those are the patients you're going to select and you need to do tests because those are the patients on whom you're going to use broad spectrum antibiotics. So for example, your patient who has community acquired pneumonia in the community, you're going to use a narrow spectrum, maybe antibiotic like amoxicillin, compared to your patient who has severe pneumonia in ICU, whom you're starting on maybe tazobactam, piperacillin, and amikacin. So those are the patients for whom you need to de-escalate. Those are the patients who are severely sick, for whom in case the treatment doesn't work, you need to know what option to use next. Yeah. The next question by an anonymous attendee. Why use piptaz instead of meropenem based on your data?
So looking at our data, meropenem was one of is our reserve antibiotic. When you look at the aware class, patient for antibiotics, in KNH we've put meropenem as a reserve antibiotic. Hence, we don't want it to be routinely prescribed. Yeah? So piptaz had an average sort of susceptibility, hence the choice in empiric choice therapies. Thank you, Dr. Jim.
Okay, thank you. So the next question, on what instances do you use a quinolone as first line?
So it depends on the patient profile. Quinolones, I think from most data, work well, especially if you suspect Pseudomonas infection. It also does very well for patients who have underlying lung diseases. It's just on the patient profile. Those ones also are allergic to penicillins. It is an option for therapy.
Okay, thank you for that response. So there's a question here about when to use metronidazole in aspiration. Is there a role for metronidazole in aspiration pneumonia?
It's completely out of these guidelines. We were strategic enough to avoid aspiration pneumonia.
Okay, yeah. Maybe I can try to answer it because I tried to look at some data once. So actually this amoxicillin, clavulanic acid, tazobactam, piperacillin, even meropenem have good activity against anaerobes. So the reason for adding metronidazole on is to cover for anaerobes. So there's no need, I guess, in that setting. So where you'd need to add on metronidazole is for an antibiotic without activity against anaerobes. So maybe like for cephalosporin. Yeah. So if you're using like a carbapenem, you're covered. If you're using tazobactam, piperacillin, you're covered. Yeah. The next question, when do you change to organism-specific therapy?
I think this should be immediate. Once you've actually gotten your lab data results, it's de-escalate immediately.
Thank you. So there's a question here about pediatrics. Maybe I'll just clarify that we are talking about pneumonia in adults. I don't know if Dr. Okiko will want to attempt. Do we use fluoroquinolones in pediatric population?
There are specific cases that quinolones can be used in pediatric populations. I think the current guidelines is only one indication for severe diarrhea due to organism. But for chest infections, I'll probably say it's good with it can be used with advice with an infectious disease physician specialist for long-term, for short-term use.
Okay, so it wouldn't be your first choice,
yeah,
maybe
because we have some
yeah.
Yes, if there's no other option.
Okay, thank you.
Where the benefit of two is. Yes.
Okay. So there's a question here about, is there a role for corticosteroid use for the treatment of pneumonia? So I think that will be answered tomorrow. There's a session on adjunctive therapies in pneumonia. There's a question here about the best dosage of amoxiclav. Is it 625 or 1 gram?
So we attempted to answer this in the guideline, and we said 625 has just about 500 milligrams of amoxicillin. And we felt the BD dose does not give us the best kinetics. So we said, if you're using 625, you better go for a TDS dosing. If you're using 1 gram, you can do a BD dose. So either of them has a good profile. Thank you.
Okay, thank you. So there's a question here. Do you do antibiotic timeout review after 72 hours and upon receipt of microbiology results? How much of ESBL do you see?
Ideally, 72 hours is a good time to review antibiotic use. If you're able to, I think we'll encourage this so that it helps you not monitor the response for antibiotic use. And once you get your culture results, then it helps you to de-escalate.
Okay. So I think the sorry, some of the posts are just comments about facilities can refer samples to the nearest gene expert site using referral mechanisms. Someone is recommending you rule out TB before you initiate anti-TBs. That's a basic thing. So, yeah, another question about, is there a role for steroids in the inpatient management of pneumonia? And then that one we said will be answered tomorrow. The last question is on how long would you extend treatment? For example, if procalcitonin is still high at day 7 of hospital-acquired pneumonia treatment.
So this is that if you have your PCT still high at day 7, then you need to go back to your lab and talk to your lab in terms of identifying antibiotic choices. Maybe a team management will help so that you sort of zero down the antibiotic choices. Means maybe the response, the antibiotic choice is still not as effective. Dr. Juma, back to you.
Okay, thank you. So there's another question that has just come in. What are the antibiotics of choice in those patients who are on treatment for TB? So it's not clear. Does he mean like a patient on treatment for TB and gets signs of pneumonia? Or does he mean if a patient has TB, what do you use to treat TB?
I don't understand that because TB drugs are still antibiotics. But I think it depends on the diagnosis. So you're looking at, I don't expect a TB patient to get pneumonia, especially on treatment. Yeah. So it's probably looking back. Is there, are your cultures right? Have you done your TB results? Have you looked at them? Maybe it's good. It's about time to repeat your cultures. So really don't add on antibiotics in TB patients. I don't think I've seen enough data to say that patients get pneumonia while on TB treatment. Yeah, unless maybe he needs to expound this question further. Back to you, Dr. Juma.
Yeah, I think that was a good response. So I think a similar question was asked on Monday, and the response was that if a patient who has TB is on treatment and then develops signs suggestive of pneumonia, you need to reevaluate that patient because it could mean different things. It could mean maybe this patient has multi-drug resistant TB, maybe your anti-TB medications are not working, maybe they have another underlying condition. Because just like you've said, anti-TBs are antibiotics. Yeah. Let me see if there's another question. Someone is asking about TB-LAM being a reliable diagnostic tool. I think this was covered on Monday. For us, we are covering antibiotics today. So, but maybe just to attempt to answer that, TB-LAM, the utility is in HIV, advanced HIV in patients, especially with the yield is best in patients with a low CD4 count, especially if your CD4 count is below 50. Yeah, so that's where the role for TB-LAM comes in. So HIV negative patients, there are no guidelines for its use in that group of patients. It's not recommended. So the setting is in HIV and specifically advanced HIV as an adjunct. So it has a lot of sensitivity is poor, so it can miss diagnosis of TB. But when it's positive, then you're relatively sure that that patient has TB. Yeah, but it can miss cases. So it's used in addition to maybe to other tests. You can get other samples as well. Someone is asking where they can get the slides. They'll be posted on the KNH website. I'm not seeing any other questions. So I don't know, Dr. Okiko, if you have any comment as we wind up.
My take is just to encourage guys. I think we need to have more local researches in this line. There is a big gap in, especially looking at the organisms that are causative agents for CAP. There is also a gap in molecular diagnostics. Especially, we should encourage guys actually to use gene experts so that we reduce over treatment for TB. Otherwise, thank you very much for listening to me. Back to you, Dr. June.
Yeah, thank you, Dr. Okiko, for that presentation and for those remarks. There are no more questions, so without further ado, I'll invite you to the webinar tomorrow at 7 p.m. Where they'll be covering adjunctive therapies for pneumonia, including oxygen therapy, including when to vaccinate, what to do with a deteriorating patient, when to basically call in the chest physicians and their role. Yeah, so I think that's it from us. Thank you so much for attending. This presentation will be loaded to the KNH website, I think maybe in a few weeks' time. Thank you, and good night to everyone.